Good afternoon, ladies and gentlemen. The next session is on the spinal injuries and the management. Here we have got 5 speakers, and I think the time limit will be around, say, 9 minutes per speaker. We are starting the Symposium 13, and initially, Dr. Saman Pushpakumara will be speaking about the mechanism, anatomy, and pathophysiology of spinal cord injury and interpretation of signs and symptoms, which is very important because the whole management of spinal injuries will depend on the understanding of the pathophysiology and the clinical symptomatology. Over to you, Saman.
Good afternoon, Chairperson sir. First, thanking the organizers for providing us this opportunity. So I'm going to go through the basic of spinal cord injury with regard to mechanism, anatomy, pathophysiology, and clinical interpretation. So I'm going, over the next few minutes, I'm going to touch these subtopics briefly. So according to the World Health Organization, the worldwide annual incidence of spinal injury is about 250,000 to 500,000, which is a fairly big number. And as we all know, it's the young productive age group that is primarily involved with this type of injury, and usually resulting in devastating long-term results, leading to physical as well as financial dependency. Over past several decades, the quality of life of victims has been improved mainly because of the supportive care like mobilization devices and so on. Unfortunately, the real neurological recovery has not been much improved over the time. That's the sad truth. So as we all know, in a normal adult, spinal cord ends at the level of L1, so lower border. So above that, someone will get spinal cord injury. Below that, it will be the chordae equina or the root injury. Most of the clinicians are more familiar about the brain injury, and we all know there are primary and secondary brain injuries. The similar concept applies to the spinal cord, but sadly, the secondary spinal cord injury may go on for years and years and years for a much longer period than a secondary brain injury unless proper management is being done. So how do these people get this primary injury? It may be mechanical compression either by a spondylolysis of the vertebra, or maybe a fractured segment, maybe a traumatic rupture of a disc, or it may be hyperextension or hyperflexion injuries, sometimes whiplash injuries, or it may be traction injuries, and those who are already having spinal cord compression, for example, with degenerative disease, are more vulnerable because the spinal cord is relatively immobile at that particular site. And like any other organs, cut injuries or lacerations can happen following either low or high velocity penetrating injuries. So during the primary cord injury, there will be a direct destruction of the neural parenchyma and also disruption of axonal network, and leading to damage microvasculature will cause ischemia as well as hemorrhage or hematoma formation, and also disruption of neuronal and glial membranes. So this will initiate the cascade of secondary cord injury. The damage to the neuronal membrane will lead to increased cell permeability and ionic dysregulation, and also the tissue injury will set in this vicious cycle of edema, further compromise of microvasculature and ischemia, and going on vicious cycle. So this will lead to a pathological release and accumulation of neurotransmitters, leading to toxic levels, and also migration of inflammatory cells with phagocytic activity, and formation of lot of free radicals, lipid peroxidation, demyelination, and finally apoptotic signaling, Wallerian degeneration, scar formation, and cyst or syrinx formation. The syrinx formation can happen at the site of injury, or it may happen at a remote site, and patient may start to deteriorate even years after the primary traumatic insult because of the syrinx formation. The primary determinants of all these pathological processes is the extent of initial destruction, for which we cannot do much as clinicians, but the most important factor that we can deal with is the duration of spinal cord compression, where we can help with early decompression. Also, hypotension and hypoxia, especially in the acute and subacute phase, can be quite detrimental to already traumatized cord. So the clinical assessment or the interpretation of signs is of paramount importance because we need to differentiate between complete cord transection versus partial injury and the degree of damage in the case of partial injury. Also, we need to localize the anatomical location and also the nature of injury. However, one need to remember that clinical level of deficits may be higher than the actual traumatic level or injured level because of the edema of the adjacent cord segments in the acute and subacute phase. As I said, the differentiation between complete cord transection and partial injury is crucial, but it may be a very difficult decision to make, especially in the acute or subacute phase, because spinal shock may mimic a complete cord transection, though still there are surviving neurons with potential to recover. So it is strongly recommended to treat any apparent complete cord injury as a potential partial injury, at least in the acute phase or until proven otherwise. Also, the value of clinical assessment is further emphasized because sometimes imaging may be misleading. Up to 1/4 of the spinal cord injuries may occur after initial traumatic insult, either during transient or in the early course of management. That is something we have to keep in mind. And also, up to 20% or 1/5 of the spinal column injuries may be multiple and non-continuous. So detecting one spinal injury at one particular level should raise the suspicion of other injuries. And always remember that imaging may not be always optimal. Although we talk about high-end MRI, sometimes this may be what you or me have to see. So you need really vigilant eyes to see some changes in a less clear or less optimal image. The vice versa also can happen. Unfortunately, I could not get the X-ray of this patient, but you can see there's nearly 100% dislocation, but the cord is intact, and the patient had near normal neurology because patient was lucky to fracture the lamina during the trauma. So it was a kind of a therapeutic traumatic decompressive laminectomy. In the examination, you need to look for spinal deformity. If you are lucky enough, or if the patient is unlucky enough, there may be obvious deformities, though less common, but more common things like spinal tenderness, contusion or hematomas along the spine, and feeling of a step indicating a spondylolisthesis may be more common. In the neurological assessment, you need to assess the neurological deficit below the level of injury and with regard to motor, sensory, and sphincter disturbance. So when it comes to the motor examination, the muscle power of individual muscle groups and the symmetry or the difference between the right and left, and also reflexes need to be assessed and documented. However, remember, grade 0 power or absent reflexes may indicate complete cord injury, or more importantly, may be spinal shock, as we discussed earlier. Same with the sensory system, the level of sensory impairment. Actually, this may be higher than the actual level of injury. And the type of sensory impairment, the dissociative sensory loss, we know in partial cord injury, certain tracts may be involved and certain tracts may be preserved. So you need to accurately document the sensation to light touch, pain, the proprioception, and also how badly each component is impaired. As I said, again, remember, the complete absence may indicate spinal shock rather than complete injury. Also, digital examination of rectum with regard to the anal tone and the patient's ability for voluntary contraction is very important, because in partial injury, this may be still preserved, although the sensory and motor impairment is near total. And also, this is one of the earliest signs to appear when someone is recovering from a spinal shock. Just one assessment is not enough. One need to do it continuously, an ongoing assessment. And the standard charts like Asia chart is very important for continuous observation and more objective assessment. And your assessment may not help with the damage already happened, the primary injury, but you will be able to stop this vicious cycle of ongoing spinal cord damage, which may go on years and years if not managed properly in the acute stage. Even after several decades, what this gentleman said in 1982 is still valid. And this would be my take-home message for the audience. Final outcome of a spinal cord injury depends upon the accuracy, adequacy, and speed of first aid management, diagnosis, and treatment within the first few hours. Charles Tater in 1982. Thank you.
Thank you, Dr. Pushpakumara, for comprehensive description about mechanism, anatomy, pathophysiology about the spinal injuries. As you all know, spinal injuries are the most devastating neurological condition in the mankind because there is a loss of independence, socio-economical problems, and the psychological problems. So with this basic understanding, I could invite Dr. Surath Munasingha, who is the consultant neurosurgeon at Provincial General Hospital, Ratnapura, to talk about the cervical spinal injury management and the outcome.
Thank you very much, dear chairperson, sirs, and good afternoon to the distinguished audience. My topic is on cervical spine injury management and its outcome. So I hope you all understand that it's very difficult to deliver a lecture on this vast topic within 10 minutes time. So it's going to be a very brief outline only. And I will stick to the topic. So, I have gone through the latest AANS, WFNS, CNS, and AO spine guidelines to give you the latest recommendations. So, as we all know, this is acute spinal cord injury. The definition is the disturbances in the whole patient, the patient's physical, psychological, and the social well-being, which impairs the patient's quality of life, the functional status, and also giving a huge burden to the society as well as the family. And we had to think about the complications in the long term as well. So we had to think about the patient as a whole rather than the injury itself, which is one of the most important factors to keep in mind. So this is the outline of the management principle. The priority is to stabilize the patient according to the ATLS protocol, as you all know. So you have to think about maintaining the mean arterial pressures, the intubation if necessary, prevention of the hypoxia, think about neurogenic shock, and identify the spinal shock. And then first, the priority is to stabilize and then detection, stabilization and detection. So identify the nature and the mechanism of the injury. And we talk about immobilization, which is of utmost importance, and the proper transport of patients to a proper neurosurgical center, especially if you're a general surgeon. And so all these things, what we expect is to prevent and minimize the secondary injury. And then go for a proper clinical assessment when stable, assess the neurology, the disability according to the scales and the classification systems, and then go for a thorough radiographic assessment. And then you obtain a thorough picture of the scenario. And then you guide by your experience, your knowledge, you guide by the literature and the classification, and also depending on the resources, then decide what is to be done, what is the ideal, operative or non-operative management. So as I said, think about the patient as a whole, not the injury itself, not only the injury itself. For example, we don't bring patients with shock to the theater for operation. So you need to optimize the patient first. So these are the objectives for cervical spine injury management, briefly. Prevent the neurological deficits, So our objective is to return the patient to the maximum functional ability with minimal pain, residual pain, and the minimum of residual deformity. So we talk about maintaining the stability as well as the concept of instability very much in this scenario, and also maintain the alignment without deformity and preserve the mobility as much as possible. So I'm sure my next speaker will talk about transportation and immobilization of the patients with spinal trauma, but I would like to tell you a few important things because the primary concern during this procedure is to prevent secondary injury. And we need to remember that certain percentage of spinal cord injuries occur either during the transit or during the early management. So a high degree of suspicion is important. Consider spinal cord injury in all patients with multiple injuries and try to prevent additional neurological damage due to excessive manipulation and inadequate restriction. And don't have a false sense of security because the patient is on a cervical collar and a backbone. And remember, not all the patients need immobilization. And once the patient is being immobilized, make sure that you remove the immobilization as early as possible because there are associated risks and hazardous effects related to immobilization. Like this, we have seen patients developing pressure ulcers within several hours, and patients, especially with associated traumatic brain injury, can have a rise in intracranial pressure as well. And these are the criteria to select the appropriate patients for immobilization. You can go through it when you have time. And regarding the transportation, what is recommended nowadays is spine board with the supportive blocks and straps, but not the stand bags and the tapes. And another few facts regarding transportation, especially in patients with associated traumatic brain injury as well. So then you do a proper neurological assessment. So what is recommended? There are few scales, Asia impairment scale as well as Frankel grade, and there are another subscales as well. So we all know the supportive management, which is very important. Try to maintain the mean arterial pressure for around 85 for at least 7 days. And think about the respiratory complications because they are at high risk of aspiration, and there is also this neurogenic shock. So the patient, most of the time, patient dies with the respiratory complication rather than the cervical cord injury itself in our setup. Right, so just a few words about the radiological assessment. As we all know, non-contrast cervical spine, CT is the gold standard. And nowadays, the evaluation of a symptomatic patient, what they recommend is the high-quality CT imaging. So if you have the high-quality CT imaging, there is no need for additional imaging with X-rays. But as we all know, in our country, we don't have CT facilities in all the hospitals. So we might need to take plain films, at least the 3-view radiographs at that time. So a few words about the C-spine clearance. So we can divide our patients into 3 categories following trauma. These are the 3 scenarios: awake patient, alert without symptoms, awake and symptomatic, and obtunded patient, which might create a few problems in decision making. So awake and asymptomatic patient, we have the nexus criteria and the Canadian C-spine rule to rule out any spine injury, cervical spine injury. If the patient is awake and symptomatic, as I said, high-quality CT is the modality of choice, which is the first-class evidence. If the CT is not available, go for a 3-view radiograph. If CT is normal in a symptomatic patient, then we have 3 options, like following. I'm not going to go into details. In an obtunded patient, sometimes a bit of dilemma. Again, high-quality CT scan. If the CT scan is normal and the radiography, the X-rays are normal, then we might have to go for MRI in that occasion. Right. Then what is the role of MRI in cervical trauma? As I said, the first line in radiological evaluation is if it is negative, then there is a place of MRI in this kind of situation, especially in a clinically unevaluable patient. And also, it is helpful in detecting soft tissue injuries like following: the ligamentous, the disc herniations, contusions, etc. Remember, missed C-spine injuries might have catastrophic consequences. And remember, avoid excessive and unnecessary imaging also for the fear of hidden injuries. Especially few words about upper cervical spine injury because they can be easily missed. So have a higher degree of suspicion, and identification is the key. So you may have to have special special, what you call these, investigations, MRI, and sometimes CT reconstructions in that as well. So we talk about instability very much in this cervical spine injuries, the concept. So these are some radiological criteria for you for instability following upper cervical trauma. You can go through it if you have time. And then we talk about these classification systems, so the scoring systems which can guide us to decide whether to go for operative treatment or not. So the most widely used is the subaxial cervical spine injury classification, or the SLICS score. This is the score which mainly consists of three categories: the morphology of the injury, the ischioligamentous complex, and the neurological status. So as you know, if the score is more than 5, you go for surgery. If the score is less than 4, you go for conservative, we go for non-operative management. If it is 4, then it's up to the surgeon. And then we also have this AO classification system for subaxial cervical spine injury, which is very informative, which gives you the information on the morphology of the injury, the neurological status, plus it has the modifiers as well as it has some grading on the facet injuries as well. Again, I'm not going to go into details. This is the fracture types depending on the AO spine classification. Again, the neurological status, the modifiers. Right. And then once you decide, once you have a clear picture, you go for your management options, are the non-operative or operative. So everyone knows the non-operative management options. You have cervical lordosis, rigid demobilization with halo, and skeletal traction in specialty fracture dislocations. Again, which is a gray area still in the neurosurgical field. And these are the indications for surgery. As we all know, the well-accepted indication is the progressive neurological deficit, and also surgery is indicated in following situations where progressive neurological deficits with significant spinal canal compromise, or may be indicated for stable, incomplete deficit with substantial spinal canal compromise. And also, there is no doubt that patient who is having an unstable spine is a primary indication for surgery, as well as deformity. And now, I'll talk about some important facts on outcomes of spinal cord injury according to the topic. So the correlation with the clinical syndromes, as we all know, the Brown-Séquard syndrome has the best prognosis, and the anterior cord syndrome, it has a poor prognosis, and the commonest, one of the common conditions we see, the central cord syndrome, which has a relatively good prognosis. And the most effective predictors of the outcome are the admission Asia score, the mid-sagittal diameter of the canal, and age of the patient according to some studies. Few facts about central cord syndrome. Nowadays, the most central cord injuries are treated surgically. The trend is high because of the improved neurological function, which limits the neuropathic pain, and also it prevents further spinal cord injury. But the only thing is we don't have much clinical randomized trials here. Anyway, the recent studies suggest that early surgery, at least within 72 hours after trauma, is safe and effective. And also it prevents the late recurrent neurologic deterioration, which we can see in some cases. The association of radiological findings and outcomes, again, the MRI T2 sequence is of very important, is of utmost importance. And as you know, the facet dislocation has a poor neurological outcome. These are the T2 findings which can give you some light to the prognosis of the patient. And as we all know, early surgery correlated with the better outcomes. So if the surgery is performed within 24 hours of trauma, it gives you a better outcome, especially for patients with Asia A injury. Earlier the better. If you can perform it within 8 hours, it's much better. And these are the studies on early management of spinal cord injury, which has proven that it has the better outcome earlier the surgery. And finally, a few words about methylprednisolone. So the latest recommendation is they suggest not offering a 24-hour infusion of methylprednisolone for the patients who present after 8 hours of acute spinal cord injury, and 24-hour infusion only for the patients who present within 8 hours of surgery, and not for 48 hours, only for 24 hours. Thank you for your attention.
Thank you, Surath. It's very enlightening the talk. on spinal cord injury. Especially, he's more concentrating on the cervical spine, which is more life-threatening. And as he mentioned, now neurosurgeons are available throughout the country in every province. And the early surgical intervention, you all can refer to the any neurosurgical center available in all three provinces. Our next speaker going to be Jagath Rathugamage. He is going to talk about thoracic and lumbar spinal cord injury management and outcome. He is a neurosurgeon at Neurotrauma National Hospital of Sri Lanka.
Thank you very much, Chairman, and all my teachers and the colleagues and chairpersons, and give me opportunity to deliver this lecture. And some of my colleagues have made very clear outline of initial management and some of the insight of spinal cord injury management. And I would skip some of my slides which I would wanted to give focus with already repeated, not to repeat the same message. So basically bimodal introduction, what you call bimodal distribution of spinal injuries in Sri Lanka and as well as we can see in other countries. And issues which we are facing is spinal injury registration, initial homeopathic treatment which can cause delay in attending spinal injury, and it is a socio-economic problem as you all know, and also healthcare cost as a poor nation now. And so in my case, I will manage management of thoracolumbar injuries is mainly on grading, decision making, optimization and operative details. And grading, my colleagues have already discussed about it, and therefore I will skip. Decision making I will try to give you as a outline. So how to deal with the spinal injury? So as neurosurgeons, we are dealing as soon as possible. So basically, there are studies shown that the intraspinal pressure is increased when there is an injury within the 72 hours. So maximum intraspinal pressure is going to be delivered at the from the day 1 up to the day 3. So if you are planning for any spinal cord injury management with the suspect of spinal cord injury, then it should be timing is important within 3 days. Therefore, as my colleagues have already mentioned, the hemorrhage, blood damage of spinal cord barrier, and edema of the dura and the pia mater and epidural components can increase intracranial pressure. And this has been done with the intraspinal pressure measurement in animal studies, and that is how we are trying to convey this message into what we call current practice. So elevated intraspinal pressure to manage is that few basics concept: osseous decompression, durotomy, duroplasty, and myelotomy, and a CSF drainage, which hardly we practice here, and specific positions and drug-mediated intraspinal pressure reduction. So for this, there are some other armamentative where we can use is a precision medicine in trauma, where the what we call involving what we call the pharmacokinetic and pharmacodynamic substances to improve microvasculature and also to reduce toxic products in what we call exerting pressure into the spinal cord injury site. So in Dennis classification, which other people have not spoken, is that the spinal cord is divided into 3 columns: anterior, middle, and the posterior column. Anterior column is consist of anterior half of the vertebral body and the ALL, and the posterior middle column is posterior half of the vertebral body and the PLL, and the rest is posterior column. So therefore, when you are planning for spinal fixation and stabilization, you need to know these 3 columns concept, And if the more than 2 columns are involved, we are taking as a unstable injury, and anterior column itself only, sometimes you may think about conservative management, and the posterior column only involved, sometimes you may even consider conservative management. But if the 2 columns are involved, then mostly operative management. And if the spinal cord injury is not only the spinal shock and as well as the involvement segments are below, then better to do a decompression as well. So, as my colleagues have already discussed, CT spine and MRI spine, and for my juniors here, to give the message is that if your cervical spine injury patient comes in, and if there is a suspicious of subluxation or anything, and first do the what you call, before putting the traction, you get a MRI done. So make sure that your hospital's setup is set in that all spinal injury suspected of cervical or thoracic to have a very early MRI before being immobilized with the traction, because the traction devices which are available in Sri Lanka is MRI not compatible, and there will be a huge delay in getting MRI after putting the skull traction. Then approach, whether to operate or whether to manage conservatively, but I will skip that because my colleagues have already mentioned about immobilization. But surgical options are whether it is to be fixed anteriorly or posteriorly or both. And most of in our practice at the moment, either we do anterior or posterior approach, and both approaches are mostly not done because of it is sometimes we feel that our what you call resources are less, or sometimes it is adequate for us to do a proper anterior approach or a proper posterior approach. In posterior approach, the pedicle screw fixation will stabilize the anterior column, middle column and the posterior column. Whereas if you do a proper anterior approach, you can stabilize the anterior and middle column. So principle of fixation I have mentioned, and this is what we are planning for the fixation. And then operative details, very important. As my colleagues are here, we are very much dependent on their support during the surgery, because some acute setting, the bleeding is a most devastating per-operative problem as well as a post-operative problem. And therefore, their what you call support is very important, and also access. So some of my colleagues are from Valisara Hospital, the National Hospital of Chest Disease is coming into play, and they are coming and helping me for all thoracic and upper lumbar fractures, and especially with regard to the unstable fractures. I will go through 2 case scenarios, and this is one of the patient, 48-year-old, admitted on in 2017 with sensory level at T10 and T12 corpectomy and fusion was done, and in between, because there was some lack of cages, we used the same rib cutting into 3 pieces and then placed the what you call lateral plate with screws. And ideally, sometimes you can put 4 screws, but depending on the size of the vertebral body and your plate, may not be feasible to do all 4 screws. And in case minimum of 2 screws down and up 1 screw is enough. And you can see that in between is a rib cage, is placed. And the next case is actually it's a L1 fracture. And similarly, I have done a corpectomy through the posterolateral thoracotomy, which my colleagues have helped me to go in, and then placed, you can see the fracture. It's a very highly unstable fracture, which have been placed in between the titanium mesh cage, and fractured vertebral segments can be compacted in this cage, and it will be a very stable fixation. And that is why I said when you're what you call fixing two columns with a great rigidity, and you don't have to think about the posterior fixation in addition. So this is a lateral approach to the thoracic injury, and most of my patients end up in Dr. Duminda Munidasa's hand. So he know how my outcomes, but I didn't want to bring all this outcome. Most of them, if you are doing for cervical spine within 24 hours, they do pretty well. And I have more than 25-30 cases. And also in thoracotomy and fixation for thorax and the upper lumbar, if I do it within 3 days, that gives a very high chance of recovery. And also patients sometimes, as Dr. Saman Pushpakumara said, the decompression. So burst fractures with the dural tear and the PLL damage, sometimes they do better because they have got some CSF leak, and that will give some sort of early protection until we fix the vertebral bodies for them to get better results. And finally, I want to tell that if you are dealing that spinal injury with the thoracic or upper lumbar, and even the cervical spine, the new concept comes in as the duratomy. So you open the dura and allow what we call necrotic substances like the dead neurons to be washed out, because there already autophagy is set in, and you wash them away and give what we call retaining nerve fibers to have a better perfusion and also to recovery. So this is my acknowledgement, and I would like to answer questions with regard to any other non-mentioned topics.
Questions will be asked at the end of the session. Jagath, thank you very much for the very comprehensive, detailed presentation. And the next presentation is by Dr. Bimal Kudavidange. He's talking about cervical spine protection and airway management and transportation of spinal injured patients, and he has had many presentations and publications on this regard, and we are very happy to welcome him to deliver his speech on this topic.
Thank you very much, Mr. Chairman, for that kind introduction, and thank you very much for the organizers to give me this opportunity to talk to you about cervical immobilization and protection and airway management. Plus, I would thank my previous speakers making my life easier for my presentation. I think this has been dealt with a bit, and I would like to give some enlightenment on some of the things. Annual rate of spinal trauma is about 10 to 130 per million cases, and the annual cost is about $2.6 billion US. That's why we should address this topic. And these dark green areas in this map shows that the burden of spinal trauma, and you can see the Southeast Asian region is the highest incidence in spinal trauma burden. So that's why we should address this. So coming into cervical spine immobilization, ATLS and pre-hospital trauma guidelines all recommend cervical spine immobilization in all indicated patients with multiple injuries. Excessive manipulation and inadequate restriction of spinal motion can cause additional injuries in addition to the primary injury. That's why we should select these patients who should be immobilized. So we can use some triggering tools to identify these patients who need immobilization, such as National Emergency Radiography Utilization Study, that is commonly known as Nexus tool, or a Canadian C-spine rule. So on your right side, there is a Canadian C-spine rule, which is commonly used for categorization of risk of unstable spine, and this has been validated in 2019 for immobilization as well. Initially, this was put down for indication for radiography, and then the other nexus criteria also can be used, which is more simpler. So in cervical spine immobilization, we need to, the assessment of spinal injured patient can be done either according to ATLS or European trauma guidelines, and then the rough classification of high risk, low risk or no risk patients can be classified according to this. If the patient is 65 years older, a dangerous mechanism of injury or a paresthesia in upper or lower limbs can be classified as high risk patients. Rather, low risk patients, when the mechanism of injury is minor or comfortably sitting in position or ambulatory after injury, or there is no midline cervical spine tenderness or delayed pain, or patient is unable to rotate the neck 45 degrees lateral, they are categorized as low risk. Whereas if the patient can rotate their neck 45 degrees either way, or have only one of the low risk classification, you can classify those patients as no risk. So according to this risk classification, we can apply the maintenance of full inline spinal immobilization. If the patient is having high risk factors of cervical spine injury, as indicated by Canadian C-spine rule, or low risk factor with unable to actively rotate the neck, or suspected thoracolumbar spinal injury, we need to immobilize these patients. Whereas the low risk factor for cervical spine injury, and if they are able to actively rotate the neck 45 degrees, or there is no suspicion of thoracolumbar spinal injury, we don't need to immobilize these patients according to the NICE guidelines. Then there is another algorithm put out by the emergency physicians, where spinal immobilization protocol. You can refer this guideline. Then come to how to carry out the full inline spinal immobilization. So, as I said earlier, there should be indication for immobilization, because there are complications if you do unnecessarily. We can put a rigid cervical collar or semi-rigid cervical collar with the supportive blocks on a spinal board with the straps. Or we can secure the spine with a vacuum mattress with a rigid collar. The contraindications has to be excluded, where the compromised airway, or a known patient with spinal deformity or penetrating neck injury, or severe swelling in the neck region, which are given as contraindications for spinal immobilization. So how to apply a collar? So this picture shows a semi-rigid collar has been applied on a patient. We have to measure it for a proper sizing before applying from top of the trapezius to the chin level, and we have to apply it with a manual inline stabilization. Unfortunately, we have a video prepared, but there's no time to give you. So you can refer it into a YouTube. So how to carry out full inline spinal immobilization in a spinal board? So we need about 4 people. 1 in the head end, 2 to handle the body, and 1 to handle the spinal board. So basically, top end person is handling the applying a inline manual stabilization on the head and neck, and first person on the chest put their hand on the shoulder and the pelvis. The second person is cross arm with the handling the pelvis and the knee, and then they will rotate the patient on the count of the head person. Then fourth person will apply the spinal board and preventing any straps going under the spinal board. Then with the count of the head person, they will all put the patient on supine on the spinal board in the center. So then you can strap him onto the spinal board, but this is not enough. You need to stabilize the head and neck to the spinal board. We use head blocks to do that. So we can apply 2 head blocks either side with the straps over the forehead and a chin to stabilize the patient on the spinal board. So applying this cervical collar and immobilizing on the, after applying this, immobilization, you need to check for the airway patency, breathing, and mini neurological examination, including checking of the pulse of all 4 limbs. And it is important to give pain relief for these patients, because if the patient is in pain, they will struggle with this immobilization. So your objective is lost. Then stabilization before transfer, it is very important that the decision to transfer these patients has to be taken by the senior level, from the referring end as well as the receiving end neurosurgical center. So they have to discuss, plan, and give instruction how and where to transfer. It is important to appropriately resuscitate and stabilize the patient before transfer to avoid any complications during the transfer. Most of the time you can avoid complications if you resuscitate in airway, breathing, circulation, and neurological wise. Then how to intubate cervical spine injured patient. So when you consider multiple injured patient, you always think about cervical spine. When you handle the A, you need to protect the cervical spine as well. So indication in tracheal intubation in a cervical injured patient is either any neurological symptoms or neck pain, altered level of consciousness, or significant blunt injury above the clavicle. These patients need to be electively intubated. Plus, you need to intubate the patients who are having brain injuries. The indications are given in the box. We usually use rapid sequence induction because to prevent aspiration, and we use manual inline stabilization to prevent secondary spinal injury. How to intubate the cervical spine injured patient? We usually use induction agents like midazolam and or ketamine. Ketamine is not a contraindication nowadays for even a brain injured patient. And then we need to properly paralyze the patient before putting down the tube. We use succinylcholine, which is a short-acting agent, or rocuronium. You have to be careful about using succinylcholine because it has to be used within 48 hours. If the gap between the injury and your intubation is more than 48 hours, you can't use the succinylcholine. Then, when you use intubation procedure, you need to maintain the manual inline stabilization by one of your colleagues. It can be either besides you or the opposite to you, and he has to hold the neck, patient's head and neck in parallel with the body. So what methods we are going to use for intubation? We have a direct laryngoscopy, video laryngoscopy, or a fiber optic. Direct laryngoscopy is a usual common method we use. It's a fast, time-tested method, and we can use bougie for difficult intubation. But the skill has to be there, so skilled person has to be there, and with the mills or manual inline stabilization, it will be difficult. Then you have the newer video laryngoscopes where you can use it with a minimal mouth opening, but of course you need to have the expertise and practice to use that. It's a bit slower than the direct laryngoscopy, and the other problem with that is the blood and the secretion might obstruct your view. Then comes the fiber optic intubation. You can do it awake or sleep, either way. You don't need to open the mouth more than one finger, and it's minimal movement to your cervical spine. This needs more expertise and the equipment availability, and then it also, the blood and secretions will also obstruct your view for proper seeing the larynx. So my take-home message is cervical spine immobilization is important in cervical injured patients. Need to select appropriate patients using tools, as unnecessary immobilization can lead to complications. Techniques we can use to immobilize is meals, cervical collars, and secure patient onto a spinal boards and head blocks. Tracheal intubation in spinal injured patients should be done if indicated, and you need to have a trained personnel and availability of adequate equipment to prevent further damage during intubation. Thank you very much.
Thank you, Bimal, for the nice description on this immobilization and the airway management of this spinal injury patient. The next topic, in fact, this management of traumatic spinal injuries is a team effort, starting from the scene of accident by paramedics, and then the A&E, accident and emergency by A&E physicians, anesthetists, and the definitive management by neuro, orthopedic surgeons, anesthesiologists, and then the ICU by critical care consultants. Then that is not going to end there. So there is a huge role to be played by the rehabilitation physician. So Dr. Duminda Munidasa is going to talk what is impossible to make possible in the rehabilitation aspect of the spinal trauma.
Thank you, Chairperson, sir. Thank you, Nirukshan, for inviting and coordinating the effort. And thank you, Satish, my good friend, and the Council of Sri Lankan College of Surgeons for giving this opportunity to talk to you. I would like to slightly give a different perspective, calling it a differently possible, because while we try to make it possible, always try to make it possible everything after spinal cord injury, as you know, the outcome is a bit difficult. Hence, we make it differently, try to make it differently possible as these pictures depict. In medical rehabilitation, what we trying to do is applying it to a disabled person with a combined coordinated use of medical, social, education and vocational measures for a training or retraining the individual to the highest possible level of functionability. Hence, this is a great teamwork, not only the physicians, but all other areas of medical professionals as well as non-medical professionals as social service officers get involved in managing your patients to their ultimate outcome. And we work with the goals set at the beginning itself. In spinal injuries, it's very much easier to set a goal because all they depend on level of injury. And as I depict in this picture, these are the outcomes generally we expect at the end of the rehabilitation process in patients who have spinal injuries, depending on their cervical, thoracic, lumbosacral regions. These neurological levels are functional levels which I'm talking about, and on that we set the goals. And these pictures will tell you what we expect of these patients if the level is not improving, which doesn't happen commonly, but there is patients who improve their levels later down with the time. So if we assume that it's not improving, these are the outcomes we expect. And all these levels are functional levels, not the anatomical level, which you will be interested in when you think about surgical options. So these functional improvement, the levels are generally well established and can be assessed through this international standard for neurological classification of spinal cord injury, and this website gives you everything to know about how to assess this. And I'm very happy Dr. Saman Pushpakumara brought in this very important document from Asian, Asia or international, the Asia and ISCOS. The American and Asia is American and ISCOS is the European Congress who put together this document which for the assessment of the neurological standards. I think this should be used in all neurosurgical units, orthopedic units, whoever doing this spinal injury, wherever spinal injury patients. We use this in rehabilitation very much because this tells us what's the patient's status, what's the chance of his recoveries, or what the level that we can expect and set our goals. This can be implemented from after the first 72 hours where we generally expect the spinal shock to go away, even though it can continue much more. But from there, it's important for us also when we refer patients to have a idea through this, and because that's give you the functional levels. It's a very easy way of doing it, but if you have to practice and learn it, and through those the website gives you, because it's very specifics. For if you know C5, the elbow flexor should be working. So it's only one muscle that you test. So, and it tells you how to test, and even the grading of 1 to 5 is, or 0 to 5 is given in that method. So please take a look at this. Try to use this in your wards whenever possible. And through this, ultimately we get what we call complete or incomplete spinal injury. Definition of a complete spinal injury is absence of sacral sensation, that is light touch and pinprick as S4, S5, deep anal pressure absence, as well as there is no voluntary anal contraction. Anybody working in a spinal cord patient should know how to examine this part, need to be done by your team members and to have it. So then, because when it's incomplete, there is a possibility of improvement of the functional level up to 3 months. And maybe from rehabilitation point of view, these patients, if you do surgery and send us early, then we can mobilize or do the therapy part early and probably achieve a better outcome in these patients. Hence, very important to know about this. And then ultimately through this, what we get is what is called American Spinal Injury Association Impairment Scale, which gives you different scales. And again, this helps us to define the likely outcome of these patients and setting our goals. Rehabilitation should start at the acute stage itself, soon as the patient comes in, together with your surgical interventions. Because if you don't do that, we will get complications like the contractures, malnutrition, pressure ulcers, and infection like pneumonias and UTIs. And as Saman said, that the importance of early management from the emergence, from at the site of the injury care to the early surgical care, for the outcome, I think the outcome at subacute stage is very important, because if you patient develop any of these problems, his outcome is going to be worse, because we cannot get our rehabilitation program going well whenever you have this problem. These are preventable, and all the team members need to be trained to how to handle and prevent these in your wards at the acute stage itself. So most important part will be paid by the physiotherapist, and then the nursing staff also should be very much conversant with these problems and how to manage. So if you now, as we have all the neurosurgeons all over the country, getting your teams ready to prevent this is very important. And we at Rathugamage are very much geared to help any team members coming and studying this and staying with this, and be conversant with how to prevent this, as well as I can always recommend Ward 80 and Ward 53 of National Hospital. The nursing staff and the therapist there works very well, and I hardly see any of these complications in the patients who are managed there. So probably that may be a better place where the acute stage patients are managed, and for anybody from outstations to send their staff in to look into this. And when you have a spinal injury problem, you get dysfunction in motor, sensory, and autonomic. So mainly it's autonomic ones cause the problems of these complications. So hence, managing them at early stage is very important. You have to promote urinary continence, and best way is indwelling catheter at the beginning. The others are for us for managed later down the rehab program. And when you have indwelling catheter, always ask your staff to look into, make sure that they change it. If their patient is there for a longer period, at least once a month or once in 3 months, depending on whether it's rubber or silicone. And important to how they keep the urinary bag, have leg straps when they are mobilized, so that can be put on strap on the thigh, or have bedside urinary bag holders. Otherwise, these keep on dragging, and that causes trauma as well as can be infection setting in. And make sure the patients get good hydration, preventing urinary tract infections. The catheter size is important. Male recommended is 14 and female is 12, and balloon should not be dilated more than 10 ml. The problem which happens sometimes is these patients get what we call urinary bypassing, and people think that it's because the catheter size is not enough or the bulb is not inflated enough and keep on increasing the size or increasing the volume inside, which cause damage to the bladder neck. Hence, why this bypassing occurs? Because these patients get autonomically bladder wall contraction. So the way to get over that is use antispasmodics, not to use the increasing size. Please make your staff aware about this. And bowel care is very important. Something which not looked into, I think, is enough in the surgical wards. They are very happy when the bowels are not opening, because that is what is going to happen at the beginning. But that cause impaction inside, as well as that is one main reason why they get urinary tract infections. Translocation of bowel flora in a stagnated bowel to the hematologically to the bladder is very common, and that's one main reason. So if you don't manage your bowel in this patient properly, you are bound to get more urinary infections. So what you need to get staff to do is prevent fecal incontinence, prevent constipation, and introduce of opening bowels regularly. Maybe once in 2 days, once in 3 days may be enough. You can use gastrocolic reflex if the patient can be mobilized, or vaginal stimulation. But in the early stage, probably if the patient is not able to sit and do these things or mobilize and do these things, manual evacuation is the only way out. So think about this and try to do that early as possible. And involve your rehabilitation team from the early stage. Maybe if you can get rehabilitation consult input, that's good. If you have some in the most of the rheumatologists are conversant with this, and we have our members around the country, and need to involve the physiotherapists and get the nurses a good training on this, and if possible, the other occupational therapists and counselors when they are available, because the devastating situation. So take home messages for you all from a rehabilitation point of view. Please try to use this international standard for neurological classification of spinal cord injuries in all wards where the spinal cord injury patient from the beginning of the day one. And it's important what we go through is through goal setting. So the above classification is very important for us. Have the skilled nursing care and physiotherapy from day one that will prevent complications and facilitating good rehabilitation outcome of these patients. Build up a ward team with these members giving training to spinal cord injuries, and we are there to help you at any time if you want to arrange. So poor bowel care and failure to prevent pressure ulcers at acute stage are two major defects observed in patients referred to rehabilitation hospital. And if they don't have these, they will have a quicker good outcome, and we can do it early. Hence, our beds will be free for take over the numbers you are sending us, because the turnover will be good. So as one of the slides says, our region has probably very much higher spinal cord injury levels because of the road traffic accidents and other home and work accidents. So we need to, the beds are very much limited, but we need to do it properly, quickly, and send them off if it's possible to get them. I would like to leave with a small printout, good outcome of some of your patients who are with us. this is that is clip from 2011 Asia Spinal Cord Injury Congress. Brainchild of that is in the audience, Dr. Arendra Pintu, and he and Dr. Lilani Palangala arranged this cultural event at that time. So hopefully we'll together work for a better outcome for our patients, and thank you very much for inviting and listening.
Thank you very much, Dr. Duminda Munidasa, again enlightening us on the post-surgical management of all these spinal injury patients. It's a long process, and in fact, it's lifelong. He major role in our or managing all our spinal injury patients. I think now it's the time to question and answers. Do you have any questions? You can go ahead.
Simple question. For the constipated patients, why don't you let them use glycerin or Darkulax suppositories? Because they can continue to do that at home very easily.
Yes, that alone is not going to work, sir, because that only make the consistency of the bowels less, loose, but that doesn't mean that you're going to open. We use it, but still you have to have a method to stimulate it to come out. Otherwise, it will just keep on leaking. So what we are looking for once a day, once in 2 days, or once in 3 days, a regular, complete bowel opening. Hence, they don't have what we call bowel accidents. So they don't need to have any pampers used.
Thank you very much for that great symposium. All the speakers did very well. My question is, can you tell me what percentage of your patients who have been operated reach the rehabilitation center?
I am Dr. Jagath Rathugamage, and there are some patients who actually come with partial spinal injury and who end up with complete recovery at the initial stage. We don't refer for spinal injury rehabilitation. And sometimes Dr. Duminda Munidasa maybe agree with that. So patients who are having persistent neurological deficit, only we are referring patients to the spinal rehabilitation. And some are with the complete neurological deficit. But with time and effort by the team from rehabilitation center, they make wonders, and they might return to us in clinics in months or maybe sometimes years of walking, or maybe having a full neurological recovery. Am I answered your question? Almost all paralyzed patients, after surgery, they will go to the rehabilitation. And none of them are being refused by doctor.
If I going to add that, sir, mainly the Western province patients have been referred, but if they are from the Avisavel area, there is another Avisavel rehabilitation center, and
also from Gandhi, Digana.
Yes, as you said, we try to take everybody who is referred. Of course, when they have major complications, sometimes we can't manage, and then especially if you have wounds and things, we don't want to block a bed for that patient while we can take up somebody else who is there. Our aim is, as I told you, that if we can get the turnover well, we can cater to most of the patients from NHSL. But I do now get referrals sometimes even from Jaffna and areas which are, so whenever where the surgeons are doing their surgeries, try to take over. But throughout the country, we are now have some sort of spinal injury rehabilitation, may not be as the fullest to the RRH, but Digana is very good. They are doing a good job there. In addition, we have the Polonnaruwa Jayantipura. Then we have one at for attached to the Badulla, and as well as Ampara. the Avisavella one is supposed to be a halfway home, which has not sort of, unfortunately, different problems with the administration. It has not gone even to that stage. And what we have is other places are Kurunegala. We are developing one, still not up to a good stand, but now still some of, I think, spinal injuries from surgeries from Kurunegala goes to that unit as well. So these are the areas we have. So numbers are not enough at all to the numbers we are getting, but rehabilitation teams are trying to cater to everybody, not only me, I have my colleague Dr. Duminda as well as our team trying our best to do it as much as possible. Of course, as Dr. Rathugamage says, it's the rehabilitation you have to decide. Some patients can have rehabilitation from home. Some patients can try to do things at home and they will improve, there's improvement. And then some patients can come as outpatient. Then, of course, in spinal injury, a lot of patients will need initial institutional rehabilitation before they be trained to be active, maybe with aids or maybe with mobilizers like wheelchairs.
Actually, I think one of the speakers mentioned about maintaining a spinal injury register. I think that's a good way to monitor all these patients. Because then we know we can keep a track on the patients what will happen. I can tell, if I have give me a minute, I can tell you another case scenario. 26-year-old patient with a high cervical spine injury was operated at the National Hospital, and he was ventilated, and then he developed a bed sore. And he was transferred to the local hospital. And then the pressure sore got worse and this thing, but fortunately I referred them to the rehabilitation hospital. They took over, but of course the patient has got already the contractures and so on. These are some of the common problems we come across. I don't want to drag this anymore.
And I think in the coming year, Duminda is going to take up a key post in College of Physicians also. So I think probably the College of Surgeons and College of Physicians get together and formulate this registry. It's going to be a very, very important endeavor to do it so that everybody knows where we are heading and what are the problems we are dealing with. And I think with that, do you have anything?
Yeah. And I think now this symposium, we were trying to emphasize and highlight that the most important management of spinal cord injury, not the spine injury. So spinal cord is very important, as Saman mentioned. Now, this is even though at the initial stage we see some the fractures only, but it is a spinal cord injury. It progresses over time, so the deformities can appear a long time after. So it's very important to manage the spinal cord from the beginning. So under the the neurosurgeons, so we are very keen to attend to these patients as soon as possible, at least within 72 hours, and the important decompression and the stabilization. So these are our key strategies. And all the neurosurgeons, again, I would like to say, in all 9 provinces now we are available. All 9 provinces we do spinal injury. So the budding surgeons, general surgeons especially, sometimes managing trauma. So you are free to talk to us and then send the patients. And then it's very important of management of spinal cord. And then, in the orthopedics, surgeons, they are managing the stabilization part plus the decompression. So these are teamwork. So we all get together. And now most of you all are interested at the moment is the rehabilitation. That also plays a major role in the management of spinal cord injury. So this is a team management, and we have to start from the very beginning. So I think the take-home message is a long-term process, and everyone should contribute, and it's a teamwork.
I'm Lochana, General Surgeon from Nuvarelia. Well, like you said, this management of spinal injury might be a teamwork between orthopedic surgeons and neurosurgeons. But when we get these patients to our casualties, we often have this controversy. I don't want to stir up the controversy myself, whether these patients should be referred to orthopedics or whether they should refer to neurosurgeons.
Can I answer this question? I would say now most of the our provinces are now covered with the neurosurgical unit, which normally managed by the board-certified neurosurgeon. And especially with regard to the cervical and thoracic, you better give a priority to refer to the neurosurgeon. And if it is a lower lumbar and the lumbar cases, very well managed, very easily managed by the orthopedic surgeons who are available at the site, because they are the numbers are outlined neurosurgeons, because we have only 9 centers and we have only 20 neurosurgeons, whereas the orthopedic surgeons are more than hundreds now in our country. So it's easily those lower levels and the stable injuries can be managed by the orthopedic team. And also the few more things which I wanted to discuss, but I because of the 10 minutes, few things which high cervical spine injury in our country is not yet geared to have what you call early diaphragmatic care. That means in India and rest of the world now using what we call laparoscopic placement of electrodes, which are being initial stage, is very much helping in respiratory care and diaphragmatic recovery in high spinal injury, which I invite our colleagues, anesthesia department, to involve and train themselves to get this what we call spinal cord stimulation at the initial stage of higher spinal injury outcome. The third thing which I wanted to tell you is, at National Hospital we have a 46 bedded rehabilitation unit, which I have failed to get adequate staff and the doctor
I think
staff.
the organizers are asking us to conclude the session. Sorry to disturb, and the lunch is there ready. Thank you.
Thank you for everybody.